Welcome to the new Retina Radio Journal Club with VBS. My name is Maura Di Nicola from the Bascom Palmer Eye Institute in Miami, Florida, and I'm joined today by Dr. Sruthi Arepalli from the Emory Eye Center in Atlanta. Sruthi, welcome.
Hey, thanks for having me.
And Dr. Barton Blackorby from the Retina Institute in St. Louis, Missouri. Barton, welcome.
Hey, thank you. Happy to be here.
All right, so we're starting today with a paper discussing endophthalmitis after anti-VEGF intravitreal injections with aqueous chlorhexidine versus povidone iodine as ocular antiseptics. The paper is authored by Nguyen Sao Tan and colleagues and is published in Ophthalmology Retina in December 2023. Barton, would you mind summarizing this paper for us?
Sure. So the objective of this study compared the rates and outcomes of endophthalmitis when using 5% povidone iodine versus 0.05% chlorhexidine. It was a single-center retrospective comparative cohort study, and they looked at almost 68,000 injections administered by 13 retina specialists. And the injection technique consisted of putting either povidone iodine or chlorhexidine on the ocular surface, and then letting it sit there for at least 7 minutes. And there was a minimum of about 5 drops of antiseptic applied at the initial application. And then the eye itself was anesthetized according to the retina surgeon's preference, some with jelly, some with subconjunctival lidocaine, some with topical. And the rest of the injections itself, the protocol was left to the customization of the retina surgeon, such as using a lid speculum, mask, or otherwise. But after that 7 minutes, which was used to anesthetize the eye, an additional drop was applied for at least 30 seconds before the intravitreal injection was completed. What they found during their findings was that the total percentage of endophthalmitis in the cases were about 0.04% in the povidone iodine group, or about 1 per 2,500 injections, and about 0.026% the chlorhexidine group, which is about 1 in about 3,900 injections. And they found that there was no statistical difference between these two groups. Both groups had 2 culture-positive cases of endophthalmitis, and there was no statistical difference between these groups. The flora obtained, some was skin-type flora and some in oral flora. And they also reconfirmed that prefilled syringes resulted in lower presumed endophthalmitis rates. So in conclusion of the paper, they found no difference in the endophthalmitis rates, either using povidone iodine or chlorhexidine. And although prefilled syringes were used more in the chlorhexidine group, they did a sub-analysis for this confounder and revealed that there was no difference in endophthalmitis rates between the two groups, and that remains statistically insignificant. But they did show that those prefilled syringes, like other studies, showed a safer outcome with regard to endophthalmitis.
Thank you so much, Barton. That was an excellent summary of the paper there. Shruti, can I ask you for a quick reaction to this paper before we go into a more in-depth discussion? Can I also ask you maybe what kind of antiseptic protocol do you routinely use, and how did you feel about the prefilled syringe finding?
Yeah, absolutely. I think this is a really important paper because it raises a lot of questions that we face in retina clinic. And interestingly, it showed somewhat different results from some of the publications that have come out before, which I know we'll talk about a little bit later. For me, some of my initial reactions were comparing what the authors did in this paper to what I use. So I typically will use 5% povidone iodine for all of my injections. We don't have chlorhexidine at my institution. If a patient says that they're allergic, I'll sometimes use gentamicin drops spaced about 5 minutes apart to clean the ocular surface before doing an injection. And I found that works quite well. In terms of the prefilled syringes, I do find that interesting, but it makes sense, right? So prefilled syringes just offer less opportunity for contamination, I think, because there's less surfaces, less steps. And so while I never anticipated that it would lead to a significant decrease in endophthalmitis, I do think it makes sense based on these papers. And it's really reassuring to see because a lot of us have adopted this within our clinical practice.
Yeah, I think you made some excellent points there. Barton, can I ask you the same question? Can you walk us through your usual antiseptic protocol for your injections?
Sure. I tend to do a combination of the techniques where I would use chlorhexidine drops before I apply my anesthetic. Basically, what I'm trying to do is kill any ocular flora that's there for as long a period as time. Then I come back, and right before the injection, I do use a lid speculum. We've all seen the patient that blinks right before you doing the injection, and then you're like, well, I need that, some anesthetic again. So I do use a lid speculum, and then I will use a Q-tip soaked in betadine right on that spot. So I tend to actually use both of these compounds, less of the betadine due to the ocular discomfort that can accompany that, but still putting it on the site that I'll do the injection, but overall cleaning the entire eye with chlorhexidine.
Yeah, it sounds like we all use a similar protocol. I have to say for myself, I do tend to use a povidone iodine much more, if not exclusively, really. And I also prefer the 5%. I like to use an eyelid speculum. And really, I think we all agree on, wanting the antiseptic, whatever that might be, to be the last thing that touches the eye. So I think we kind of all agree on that. Thank you so much for this very interesting thoughts. We will take a quick break, and we'll reconvene after the break, and we'll hear a little bit more of a longer discussion about this interesting paper. Welcome back to the new Retina Radio Journal Club with VBS. Once again, I'm joined by Dr. Sruthi Arepalli and Dr. Barton Blackorby. So let's go a little bit more in depth in the discussion about the paper that Barton just summarized for us. So Sruthi, I'm going to start with you because you actually moderated recently another episode of our journal club here, discussing the findings from a different paper that was authored by Amit Mishra that actually came to different conclusions. They also compared chlorhexidine versus povidone iodine, but they favored povidone iodine in their results in terms of the rate of endophthalmitis. So what do you make of that, and how do you actually deal when you're trying to interpret papers that assess similar things but come to different conclusions?
Yeah, it's a great point. So I believe in the Mishra paper, there were a couple of differences. One of the big ones was the concentration of the povidone iodine they were using. And, that can theoretically make a difference on your ocular load of bacteria or pathogens. So they used a higher percentage. And that may explain why they had some increased benefit with using that versus chlorhexidine. I think it's tough when we're comparing these papers because they're not all following the same protocol exactly. And so my main takeaways for these when I talk to my patients is that we have pretty good safety and efficacy with both of these antiseptic choices. And while I feel more comfortable with povidone iodine, because that's what we have freely at Emory, there are other options for them if they insist that they can't tolerate it or have had bad experiences with it. I think the other thing as well is understanding what my patient profile looks like compared to any of the papers and seeing if we can extrapolate and how we can kind of expand on those findings for the person sitting in front of me.
Mm-hmm. Those are excellent points. What about you, Barton? How do you kind of handle this kind of in a way conflicting results?
When I see papers that have two different outcomes of the same thing, I kind of dive into the weeds of how did they get to where they got to? What was their technique? So in our first paper here, they washed the entire eye with anesthetic, so either betadine or the chlorhexidine. But in the Mithra paper, they just use a Q-tip on that site, which is a big difference between the two papers. And personally, for me, I like to cover the entire eye initially with the chlorhexidine, and then I'll use the Q-tip with the betadine, but I've applied it to the entire surface. So I'll lean more towards a paper that's similar to my technique. And the other thing that I look at in the secondary paper, they use a chlorhexidine that was based in a 4% alcohol solution, which we don't typically use here. We have it in an aqueous solution. I'm not an expert on chlorhexidine itself between the two, but I'm going to start looking at the paper and the outcomes according to what's available to me in my clinic and help me make that informed decision.
Yes, and I agree completely. These are all excellent points. I think it's important to really be able to interpret and, as you both mentioned, extrapolate the data and really apply it to the kind of patient that is most applicable to, obviously. Now, I think we've all have had to, deal with patients that really are sensitive to povidone iodine and really cannot tolerate it. Some of them report an allergy. I want to hear your thoughts about how you feel about this, and maybe we also know that that there's no real allergy to povidone iodine, but certainly the discomfort that some of these patients feel can be very important in terms of impacting adherence to therapy. So Barton, maybe I'll start with you on this one. How do you deal with these patients, and does having papers like the one that we're discussing help you in feeling more comfortable in finding an alternative to maybe the more traditional method of antisepsis?
I think it does help me knowing that I have an alternative if I really have a stubborn patient that says I cannot tolerate betadine. If I'm in a clinic where I don't have chlorhexidine available, I still, I kind of put my foot down and say, we're going to use betadine because I still have to take care of the patient, even though they don't understand the risk involved of switching potentially to a different agent. But what I do is a lot of hand holding after that. I say, we're really going to irrigate this eye out well. We can even put a little bit of some erythromycin ointment at the end. I'm going to tape your lid shut. I want you to keep it shut for the next hour and take that off. And you just go that extra mile afterwards. And for the high anxiety patients, I think that takes care of a lot of that discomfort they're feeling. And even for our patients who may have more ocular discomfort, those extra steps also help soothe that eye, and I find better outcomes from them.
Absolutely, I agree completely. A lot of our job is to really, talk patients through the process, and just really make sure that we're catering to their individual needs. I agree completely. Shruti, what about you? How do you handle these situations?
I agree. I think there were some excellent points that were brought up. One of the other things that I will do is in a patient who insists that they're having an allergy, sometimes I'll ask for them to come back the day or two after to take a look at the surface of the eye, because sometimes you can see that after the numbing has worn off, they may have scratched themselves or done something during that numbing period, and then we can see it and they're attributing that pain to an allergy. Or I can show them this is your reaction, but it's not a true allergy, and kind of having more data points can sort of bring them over or around to using the povidone iodine a little bit more too.
Yes, that's an excellent point. I've definitely been in that situation before. The other thing I will say, I have a few patients that insist on having really just one drop of betadine. So in that case, I will be the one to administer that drop. I will, reassure patients that I will make sure it's only one drop, and I will also, reassure them that we'll wash the eye profusely afterwards. I agree with you both completely. I do not feel comfortable not doing anything. Some patients have asked to not have any sort of antisepsis done, and I, highly advise against that, obviously, like I believe we all do. But having studies such as this one that show that an alternative is feasible and has a good safety profile makes me feel a little bit more comfortable potentially switching some of them to something different. The last point I wanted to bring up is that, and that was brought up in the paper, is that it sounded like most of the specialists in this retina group switched to the chlorhexidine protocol right before the pandemic. And so all throughout the period of the pandemic, they were using masks, both the physicians, the staff, and obviously the patients as well. How do you guys feel about that? Do you mask yourself? Do you mask your patients now that we are in a post-pandemic world? How do you feel about that? Shruti, we'll start with you.
Yeah, so I mask all the time, but mostly it's for not even really infection risk, or I guess for myself, it's my protection, because I found that after COVID, the more that I masked, the less sick I got after a busy clinic day. And so I think it helps with exposures for me. Most of my patients don't mask anymore. So there's maybe one patient a day who masks. And if they do, we either have them remove the mask for the injection, or we'll tape over the nasal bridge so that that air doesn't hit their eye. And then otherwise, I just institute a pretty strict no talking policy, regardless of the mask, and tell them that, oral flora can get on the needle and other things, and that's what we worry about the most.
Perfect. What about you, Barton?
I do the same. I try to mask as much as I can. And in the summer here in St. Louis, when it's really hot, it's a little bit hard to start to sweat under it. But I do try to mask mainly for myself. But for my patients, I do the same thing as Shruti. I have a very strict no talking protocol. So as soon as I open the box, I tell the patient, we're all going to stop talking now. Just keep our mouth shut. If they do talk during that time, whatever step that I was on, it typically repeats. So if I'm about to stick the bottle, I'll put some alcohol in it again, or I'll get a new needle out just and say, hey, let's just remember, be real quiet during this time. I have hand signals for my technicians. And then as soon as we're done, we can talk again. I do the same thing with their mask, where I have them remove it or I tape the bridge.
Agree completely. It sounds like we're all on the same page. I mask myself, do not have my patients mask, and very few patients mask in Florida, and also have a very strict no talking policy. So, well, I think we covered a lot of interesting points in this episode. Thank you guys so much for participating in the discussion. Thanks to our listeners for tuning in, and please stay tuned for new episodes with the Journal Club of New Retina Radio. Thank you so much.